Thank you for joining me in this CME activity. My name is Dr. David Binion. I'm a professor of medicine, professor of clinical and translational science in the Division of Gastroenterology, Hepatology, and Nutrition here at the University of Pittsburgh School of Medicine. We're going to be talking about new guidelines in the treatment of C. difficile infection, which have come from the Infectious Disease Society of America that were published earlier this year in 2018. In addition to reviewing some of these new changes in treatment recommendations for C. difficile, we're going to hear from a patient's perspective. We're going to get something perhaps a little bit unique, hearing how C. difficile can truly impact the life of an individual in a very negative way. And then we're going to talk about a third area, which is shared decision making, where we actually have our patients playing a more active role in the choice of options for the treatment of this illness. As part of this activity, we're going to hear a patient's perspective, someone who has actually gone through recurrent C. difficile infection. Our patient is Kathy. She's a 69-year-old woman who has a history of diverticulitis, and following her fourth episode of antibiotic therapy for diverticulitis, she contracted C. difficile infection, and we're going to hear her saga in terms of what happened to her over the ensuing years.
When I was first diagnosed with C. difficile, I was in the hospital being treated with diverticulitis. My attending physician came in the day of my discharge and said to me, "Oh, by the way, you have C. diff." I had never heard of it, and I asked him, "Well, what is C. diff?" And he said, "Oh, it's a colitis infection. Not to worry, I gave you a prescription for it," and I was dismissed. The information that I was provided by the attending physician was none. He did not tell me about the morbidity. He did not tell me about the risk of a reinfection. I got virtually no information whatsoever. I was left in the dark. I was just dismissed with prescriptions and told to go home. I had had no idea that I was at risk for C. difficile when I had diverticulitis. I had never heard of C. difficile. I didn't know what it was. I knew that diverticulitis was a very uncomfortable situation, and I had suffered from it previously, starting back in October, and that had been my fourth occurrence when I had it in December. But no, I had no idea that diverticulitis could lead to C. difficile. My first reoccurrence was the end of January of the following year. I had again had a diverticulitis attack, and the decision was made to remove my sigmoid colon. After that surgery, I went back to my surgeon for my weekly check, and I didn't feel well. And she was very concerned, and she readmitted me to the hospital. Upon readmittance, tests were taken, and I was diagnosed with another occurrence of C. difficile.
It is essential for us to provide as much information as possible to our patients regarding their healthcare issues and their healthcare decision making. Clostridium difficile infection has increased dramatically in the United States over the past 20 years, so more patients might be aware of this infection from having had contact with either friends or perhaps family members who've contracted it. Nevertheless, it's really important for physicians and healthcare providers to provide guidance, to provide information to our patients regarding the epidemiology of the infection, the potential for reinfection. We all know that C. difficile is a spore-forming organism that can be contracted from exposure from the healthcare setting. Patients who have had antibiotics are at a markedly increased risk for contracting this infection. And simple things like hand washing with soap and water will actually reduce spore burden. The IDSA guidelines, which were published earlier in 2018, actually specifically recommend that patients have hygiene. They actually wash their hands, bathe in order to decrease skin contamination, which may lead to recurrent infections. When we think about the treatment options for C. difficile, I think it's important for us to have our patients be aware that we fully expect 25% of our patients who have been treated for their first infection with C. difficile that they are at risk for a recurrent infection within the first 60 days after that initial infection has been treated. The field of C. difficile infection and C. difficile treatment has actually evolved dramatically in the past several years. C. difficile was first suspected to be a pathogen in humans back in the 1978-1980 time period, and there were very limited treatment options available for approximately 25 years. Oral vancomycin was the only FDA-approved agent for the duration of that time period. Metronidazole, though never approved by the FDA for the treatment of C. difficile, became one of the mainstays of therapy during that early time period. Over the past several years, there has been a dramatic advance in our understanding of the mechanisms that lead to this infection. This has really become a necessity because of some of the epidemics that have occurred in the United States, North America, and actually throughout the world with C. difficile infection. In addition to our understanding of the mechanisms of infection, how this infection occurs in individuals, we have a better understanding of treatment options, things that we can do to help our patients move forward. And the IDSA guidelines really reflect some of our best clinical knowledge at this time. And the IDSA guidelines have actually made some important changes in terms of treatment recommendations for first infection. They've simplified some of the therapeutic options in some regards. When we think about the choices that are most effective for our patients, they've provided guidance in terms of recurrent infection, which is a very important issue because C. difficile is highly associated with recurrent infection. We have new recommendations regarding fulminant disease. And lastly, we have some recommendations regarding a very novel form of therapy, which is the fecal microbiome transplant in an attempt to restore the microflora in the bowel. The updated IDSA guidelines are in some regards a simplification of some of the guidelines that we had been able to use over the past several years. I refer back to the ACG guidelines in 2013 and some of the prior IDSA guidelines published back in 2010. There's been definitely an attempt to stratify our patients in terms of their disease severity, and the IDSA guidelines have simplified this. They actually make a distinction between non-severe and severe C. difficile. But what's particularly interesting about the current IDSA guidelines is that the antibiotic recommendations are actually the same for both a non-severe and a severe C. difficile infection patient. Based on new data that has emerged over the past several years, metronidazole is no longer recommended for the first infection of C. difficile in our patients with either non-severe or severe disease. We have a recommendation now to use oral vancomycin, 125 milligrams 4 times a day for 10 days, or fidaxomicin, 200 milligrams twice daily for 10 days, as the preferred superior strategy for initial infection for either non-severe or severe C. difficile infection in adult patients. So the current IDSA guidelines for the treatment of the first recurrent infection from C. difficile have also been, in some regards, simplified. There's a recommendation to use vancomycin with a pulse taper regimen over the next several weeks as a strategy to reduce recurrence. There's also a formal recommendation to switch from perhaps vancomycin to fidaxomicin with the 200 milligram twice daily regimen for 10 days. And there is an additional recommendation if metronidazole had been used as a first treatment option to make the switch to either vancomycin or fidaxomicin as the second antibiotic choice in that individual. When we think about risk stratification for patients who are potentially at highest risk for the development of a recurrent infection, we do have information that has emerged in the literature. The IDSA guidelines definitely go over this information as part of their summary of recommendations. I think it's pretty clear at this time period that older individuals, perhaps individuals greater than age 65, are at risk for increased recurrent infections. And this may be a proxy for actually having comorbidities. Individuals who have had a need for ongoing antibiotic therapy when C. difficile has been detected are at a markedly increased risk for recurrent infection. It's perhaps 5-fold higher in this patient population. When we have patients who are requiring cancer chemotherapy, immunosuppression as a result of problems with inflammatory disorders, the need for corticosteroids, patients who've undergone organ transplantation or bone marrow transplantation. These are all populations of individuals who are at a markedly increased risk of experiencing recurrent C. difficile infection. When we start to think about populations that have a markedly increased risk of experiencing recurrent C. difficile infection, there are options therapeutically that we might be able to target. There are antibiotics that have emerged with a decreased spectrum of activity, which is really an important consideration. Fidaxomicin was shown in pivotal trials to have a reduced risk for recurrence over a 60-day time period that was significantly better than oral vancomycin therapy. If we think about other options that could be considered in a population that is at a markedly increased risk for recurrent infection, actually providing a passive vaccine, an immunization in some regards, where we can provide antibodies that target one of the C. difficile toxins, C. difficile toxin B. And this is the compound bezlotuximab, which has been FDA approved over the past year for the treatment of individuals who are recovering from C. difficile infection, but individuals who are specifically at marked increased risk of developing recurrent infection. So if we think about some of the tools that are available to us now, we can actually potentially start to match up high-risk patient cohorts with some of our best strategies that will perhaps decrease the risk of a recurrent infection over that 60-day time period. The IDSA guidelines have recommended the use of oral vancomycin and fidaxomicin for the treatment of both non-severe and severe C. difficile infections. But there are some distinctions that we need to think about when we consider the choice of vancomycin or fidaxomicin. Vancomycin is highly efficacious in the treatment of C. difficile, but vancomycin potentially can stress the C. difficile organism and actually contribute to spore formation. And C. difficile spores are believed to survive for approximately a 60-day time period. They can contaminate the environment in which a patient is located in their home. Skin contamination is actually very, very common in individuals who are at the completion of a successful initial antibiotic course. And we believe that the spores that are either on the person, perhaps still colonizing the GI tract, or in the patient's environment may in fact contribute to recurrent infections. Fidaxomicin, alternatively, is an antibiotic with high anti-C. difficile activity, but does not appear to have the same predisposition to create spore formation in the C. difficile organism. This may be a contributing mechanism to why recurrence rates with fidaxomicin were actually significantly lower than are typically seen in oral vancomycin therapy. The IDSA guidelines, which were put together in the year 2017 and actually published in early 2018, do not specifically make recommendations regarding bezlotuximab. Bezlotuximab was mentioned in the summary of the data that was reviewed for these guidelines, and it basically stated that some of this information was too new to be included in the formal recommendations. When we think about what bezlotuximab actually can accomplish, this is a antibody, a recombinant antibody, an IgG1 structured antibody that targets the C. difficile toxin B. FDA approval is to specifically use this antibody in a high-risk individual who's at risk for a recurrent C. difficile infection as a component of a successful initial antibiotic therapy. Now, we believe that the bezlotuximab will actually neutralize C. difficile toxins. It will actually improve barrier integrity in the epithelium of the GI tract, and that may mechanistically help that individual get through the high-risk time period, which is the first 2 months after a successful antibiotic course. So bezlotuximab does not have a specific recommendation in the current 2017 IDSA guidelines, but we expect that clinical information will emerge over the next few years, which really substantiates the use of these approaches in targeted populations who are at the highest risk for developing a C. difficile recurrence. The IDSA guidelines published earlier in 2018 have some important distinctions with some of the prior guidance that has been published over the past several years. The IDSA guidelines have in some regards simplified the therapeutic armamentarium for C. difficile. What I mean by that is that metronidazole has actually been removed as a first-line agent for individuals who are experiencing what is felt to be a mild or a non-severe infection with C. difficile. The rationale for removing metronidazole as a component of initial therapy for C. difficile in the adult patient population stems from the fact that there is less effective performance of this antibiotic in more recent clinical studies. There appears to be higher rates of recurrence when metronidazole is used for C. difficile infection, and also efficacy is not as substantial compared with oral vancomycin or fidaxomicin. So there is a growing body of evidence that metronidazole is an inferior agent, and in part because of this new data that has emerged over the past several years. The IDSA guidelines have removed metronidazole as the recommended choice for either non-severe or severe infection. Metronidazole can be used in an appropriate setting, perhaps a patient who has no other therapeutic options. It is still worthwhile using this. Intravenous metronidazole can be used in patients who are experiencing fulminant disease in combination with oral and rectally administered vancomycin enemas, simply because of ileus or an inability to get antibiotic into the GI tract of an individual who's experiencing these more severe complications.
Upon having C. difficile the first time, I took the medication and was hoping that I would be fine and that life would go on as normal. That wasn't the case. I had a reoccurrence, and taking the medication again was not successful. With each continuous reoccurrence, which used to happen about 2 weeks after I stopped the medication, I would get the C. difficile back, and it was more vicious than it was the time before. I wasn't able to leave the house. I was confined. I was sick all of the time. I was nauseous. I had cramps. I spent the majority of my time in the bathroom. It wasn't possible for me to have any normalcy in my life at all. And as life has progressed, I'm still damaged. I am still unable to do, without having to think very carefully, some of the normal things that people do to enjoy life. So I'm very limited in the decisions I make as I go forward in life, because things are different, and I have to be cognizant of the fact that it'll never be the same. But I do have back some quality of life, and for that I'm thankful. When a trip is planned or a social event is planned, I always need to think ahead. If I'm going out to do something as simple as eat with friends, I never know if I'm going to have to stop in the middle of a meal, whether something is going to agree with me or not agree with me. The first thing I do when I enter a restaurant is I find out where the restroom is. If we're traveling for any length of time, there's always a bucket in the car, a change of clothes, towels, just in case something is going to happen. And even after the fact that I am now C. diff free and have been for 2 years, I still have reoccurrences of having abdominal upsets, and they're not predictable. So life in general is not the way it was, because I'm always thinking ahead and wondering, is this the time when I go out when there's going to be an emergency?
The patient who shared her story with us on this activity, Kathy, is a 69-year-old individual. Based on her age alone, she's at an increased risk for having recurrent infection. Age may in fact be a proxy for comorbidities, and we know that individuals who have concomitant illnesses may actually have increased risk simply because of their health condition in general. The diverticulitis infection that Kathy was being treated for required ongoing antibiotic therapy, and we know that a person who is diagnosed with Clostridium difficile infection who requires additional antibiotic therapy for a specific indication is going to be at a markedly increased risk for recurrent infection. So I think she actually hit 2 of the important clinical red flags that we can easily identify for an individual who will have an increased risk for developing a recurrent infection. Now, the patient's testimony, Kathy's testimony, described having multiple recurrent infections. An individual who has had a first recurrence is declaring themselves to be a particularly high-risk individual, and this is a third clinical risk factor that she has identified. And when we have this type of an individual who has unfortunately gone down a very negative trajectory, this is perhaps the individual who could in fact benefit from a more selective antibiotic approach. And this is where the compound fidaxomicin may actually be best positioned to try to stop this trajectory, because with each recurrent infection, the chances of having a successful antibiotic clearance of C. difficile are markedly lower. When a person has had multiple recurrent infections, it's actually worthwhile for us to think about humoral immunity, the ability of that individual to mount an antibody response against C. difficile toxins. There are individuals who have perhaps hypogammaglobulinemia, a decreased ability to make an antibody response. This might be iatrogenic as a result of corticosteroids, perhaps immunosuppressive therapy. But these individuals are going to, again, perhaps be the subgroup who would have the most benefit from receiving the recombinant IgG1 antibody that actually targets the C. difficile toxin B as a component of their therapeutic treatment. So I think this individual, Kathy, has actually described in some regards many ominous features: elderly individual, need for ongoing antibiotic therapy, having had a first recurrence. This is somebody who's going to be potentially going down a very negative pathway, who may benefit from some of our newer and perhaps more effective therapies moving forward.
On my recurrent episodes of C. difficile, there were very few decisions that I was able to make. My physicians had a path that they wanted to take. They had a prescribed medicine that was supposed to be able to get the infection under control, and the rest of my system was supposed to take over and replenish it, and I was supposed to be fine. Obviously, that didn't happen because the reoccurrences went on and on and on. They would change the frequency, they would put me on tapers, but the result was always the same. At the end of 14 to 12 days after I got through taking the medication, the C. difficile returned with more vengeance than it had the time before. Being empowered to try to discuss this with my healthcare team was very difficult. The window was very narrow in their perspective as to what you did to treat this disease. And because I was not aware of exactly what the infection was and how it occurred and how to get rid of it, I didn't really have the knowledge to be able to sit down and carry on a conversation with them that would lead to any kind of an agreement. I more or less had to listen to what they advised me. I was the patient, they were the physician. I was to put my trust in them, and they were going to make this infection go away. It didn't happen. After I was diagnosed with the 8th infection of C. difficile, I was devastated. My husband had taken the specimen to the hospital because after a 9-month taper, I was positive that I was done with this infection. It was over with. But I began to have some unusual symptoms. I called my physician. They said, let's do a test. And I was almost going to tell them, well, that's not what it is. This has got to be gone. The test was taken, and unfortunately, it was positive. And at that point, I went into the bedroom, I laid on the bed, and I started to cry. I said, I can't do this anymore. I cannot do this anymore. And at that point, I knew that I had to take control of my destiny, and I had to start advocating on my own behalf.
Shared decision-making is a concept where the patient is going to play an active role in deciding which treatments are going to be used for themselves. Actually, this is really a key component of having the best outcomes in any type of medicine. We really want to be creating a team. We want to have a therapeutic alliance with our patient, and we don't want to be paternalistic when it comes to deciding which treatments are going to be best for our patients. Because there are new therapeutic advances in the treatment of C. difficile, I think it's important for our patients to be aware of this. These are FDA-approved treatment options, so I think it's fair for physicians and healthcare providers to share this information with our patients. We know that there is a subgroup of patients who experience a C. difficile infection who will have recurrent infection. Those individuals with recurrent infection in particular, these are the individuals who really do need to know about some of these best options that have become available. When we think about some of the new guidelines from the IDSA, I think one of the important gaps in healthcare provider knowledge is the simple fact that these options have become available and may offer an improved strategy for that individual who is unfortunately going to be at the highest risk for having recurrent infection. Now, shared decision making is most commonly thought of as a part of chronic disease management, when a patient might need to be on maintenance therapies. If we think about problems like inflammatory bowel disease, putting a person onto a biologic regimen, making sure that they understand the ramifications of going onto these therapies. Some of our other areas, like infectious disease, may not have had as much of a component simply because an infection might have been a single episode. C. difficile might represent a unique, perhaps distinction in this space, because we do have individuals who are at a marked increased risk for developing recurrent infection, and we have new tools available that are going to be a part of the therapeutic choices that a patient might have. So a patient who has gone through multiple recurrent infections should definitely be aware of different antibiotic choices that have perhaps better therapeutic efficacy when it comes to preventing recurrence, and also the recombinant antibody technology that we have available, FDA approved, to help prevent recurrent infection. There are important pragmatic issues when it comes to healthcare, and one of those is health economics. Some of the approaches that we've talked about, antibiotics with a more expensive cost, antibody-based therapies, are oftentimes going to be positioned or tiered so that they may not be accessible to some of our patients. These are some of the important clinical challenges that I think are going to be facing us in the healthcare of patients with C. difficile infection going forward. I would say that data will emerge in all likelihood over the next several years, which demonstrates that the highest risk individuals who will experience recurrent infections that lead to hospitalizations, surgeries, even unfortunately increased mortality, these subgroups of patients are going to perhaps be the easy subgroup to identify that would benefit from an improved therapeutic approach to C. difficile infection. I think part of the challenge that we've had is that C. difficile is something that all healthcare providers are pretty comfortable with. They see it on a regular basis, but they may not be aware of some of this newest data that suggests we can do a better job. Stratifying our patients, identifying who is a severe infection is essential. We have to be more vigilant in that cohort. We have to be wary about recurrent infection, and if we have an option to prevent recurrent infection, I think that's really going to be the clinical unmet need that is going to be facing us in the years ahead. So I think there are some important take-home messages that we can remember from this activity. There are subgroups of patients who are at a markedly increased risk of contracting a C. difficile infection and actually experiencing recurrent infections. These can be summarized fairly simply as patients who have inflammatory bowel disease. They have a dysbiotic flora to begin with, and they're oftentimes on immunosuppression and corticosteroids, which will provide a increased risk for developing C. difficile and recurrent infection. Oncology patients, particularly patients with bone marrow transplantation, a markedly increased risk of developing C. diff and recurrent infection. And the transplant patient population, individuals with solid organ transplants, particularly the lung transplant patient population, again at a markedly increased risk of infection and recurrent infection. If we remember that patients who have need for ongoing antibiotic therapy in the setting of C. difficile infection, this is again an easily identifiable clinical red flag of an individual who will face a markedly increased risk of C. difficile infection going forward. So there are things that can be easily identified at this time period that will help to stratify our patient population and potentially allow us to match up our most effective therapies with patients who have the worst potential clinical trajectories. And hopefully we can change that for the better and improve our patient outcomes. So the IDSA guidelines have also simplified some of our recommendations for the initial therapy. We no longer position metronidazole as a first-line agent for the treatment of C. difficile infection, in part because it has proven to be an inferior agent for the majority of adult patients. We are actually recommending vancomycin and fidaxomicin because of this improved efficacy as a frontline therapy for both non-severe and severe infection in our patients. Thank you for joining me in this discussion of some of the newest guidelines regarding C. difficile therapy and engaging patients in the decision-making regarding treatment options for this infection. I would encourage you to look back onto this website for future CME activities and also to complete the questionnaire to receive credits for participation in this activity. Thank you.